I mean, I have the same trouble like you have, but if after repeated injections people are pain-free and partners notice it, but it doesn't last longer than maybe in the beginning the cortisone is doing something.
Okay, one more time. I know what you're getting at. One more time. I don't have the perfect solution. Okay, if I had, we wouldn't be sitting here. Okay, or if he had, we wouldn't be sitting here. Seemingly, it's not perfect. Okay, seemingly it's not perfect. And all I'm saying is I would be very careful. And the question I was asked is, do I consider this as a must-have? I don't for the time being. That's all I could say. And I would be careful, because maybe this patient you just described is the ideal candidate who profits from the procedure. But if you widen your indication, and this is usually what happens with new technology, then this patient will not receive it any longer, because it's not going to be on the market in 5 years from now.
And variability, because I think the variability is the huge problem, and how do we make this reproducible? And also, this is a process, it's not just a device. And there's very little attention being paid to the process issues that lead to success. And so I think even with one technique, we're seeing in this meeting tremendous variability in success rates using the exact same operation, which points to the fact it's not the device, it's the process.
Or a combination.
Right, and also I'm not a big fan of industry-sponsored studies as a bias. Having said that, I'm reviewing 150 placebo-controlled trials in surgery, which is shocking to find that there's that many, and the industry-sponsored ones end up being better quality. And that was against my assumption of my bias going into the review process. So I think it's a mixed bag. There can be spin, but there can also be better quality because you have a whole team as well. So I think it's a mixed bag there as well.
Yeah, we've got to have certain rules. If it's true, because the money is there. Otherwise, you couldn't do research nowadays, because public funding goes into heart, neurology, whatever, not into this field. But on the other hand, there got to be rules for that. And as long as I don't know that these rules are kept, I'm skeptical, that's all.
And the caveat to that is the real breakdown is at the editorial level where they allow these things. And I think that if we're going to point a finger, that's where it needs to be pointed.
Yeah, that's what I did.
But if an image is worth 1,000 words, I would say statistic is worth 1,000,000 words. And I was missing a little bit statistics. And I would agree with Professor Meyer that before deciding whether sacroiliac joint fusion is a standard of care or not, far more statistic has to be done. And to make an effort to convince colleagues that it's a reproducible method.
The issue of ghostwriting is not something that we ascribe to. The reason there are 2 employees on the authorship of that paper is because they participated in analysis of the data, the statistics, and as such, according to journal standards, they were obligated to put their names on the paper. The data is not hidden. We have given the data to Yale, where Dr. Wong is from, the Yale Open Data Access Project. Our primary source data is available to investigators from around the world. They submit a request to Yale and say, we want to look at the SI bone data, primary source data, CT scans, outcomes instruments, everything that's there, and we want to look at it. So we are about transparency, and we have made that commitment. That's unusual for industry, but we feel that, particularly with the SI joint, there is significant interest in looking at that information. The last thing that I'd like to address about industry bias, we know that industry-sponsored studies, as Dr. Freeman had mentioned, are typically higher quality. They're more likely to be randomized. They're more likely to have multiple centers, and the quality of the study is usually better because it costs money, as you yourself said. There's another issue that has not been addressed, and that is the issue of bias in the editors of the journals. There's no transparency, there's no accountability, there's no exposure to the articles that are submitted, the articles that are accepted. They answer to no one. There's no transparency in that process. So we would just ask that the academic elite perhaps held themselves to the same standard as they hold industry.
Many of the things you said, very good. I didn't know, especially that your raw data are accessible, which is excellent. I agree with many of the things that you say. I disagree with the fact that it's impossible to do a sham procedure. I think nowadays that is possible, and that would have helped you, according to me, with that. And I do agree that the standard of defining the patient is the standard which is the best available. I'm just saying it's not a perfect one, because SI joint pain is a difficult disease to define. It still remains.
And the solution to his questions, how to get a good study, was, in our opinion, to found an independent association. We tried to approach the German Spine Society, we tried to approach, maybe not in the right way, the Orthopedic Society, mentioning that there is a problem like the sacroiliac joint and it should be discussed publicly. The surgical treatment, we all don't know if this really will lead to good results on the long run, especially if you don't find the right indications. And we need to set up something like that, and maybe you can help us.
Yeah. One more time. The question to me was, is it a standard of care now? And the answer to that, with the data available, is no. I do fusions of the SI joint.
So if we are reporting improvement of 20% or greater, yeah, you need a placebo or sham surgery. But if it's 50% or greater outside the range of disease variability and bias, that's a different number. So I'd appreciate your thoughts on that.
Yes, the latter is important. Well, if you have a treatment effect like that, the question is, if you do a sham control, that means you just, whatever, stab a needle in or just do something, and you see that the treatment effect is just that little, you could have probably something to treat that disease even less invasively, with less complications. That's the beauty of having a sham.
Yep.
Okay. As I said, I'm doing the same. I just give myself the luxury of doubt.
Yep.
And with that, probably you advance knowledge.
So we can conclude that we agree. Okay.
Well, we agree on the fact that it's not a standard of care?
Yeah.
Okay, well then, done deal. Okay, thank you.